Hi, good morning. My name is Lieutenant Commander Danielle Cuevas. I'm a SRNA out of Naval Hospital, Jacksonville, going to discuss respiratory physiology. The most commonly used anesthetics are inhaled and depend on the uptake and elimination of drugs by the lungs. Many of the medication we use affect the lungs' normal physiology. In addition to the medication alterations, the way that we position a patient in a particular surgery can also have effect on the normal physiology. Contractions of the diaphragm cause the base of the thorax to descend 1.5 to 7 centimeters, expanding the lungs, accounting for 75% of the change in volume, also causing abdominal contents to be pushed downward. Accessory muscles of the rib cage with movement upward and outward account for the rest, together increasing the volume of the thoracic cavity. The external intercostal muscles are not usually utilized during normal breathing, but during exercise or during respiratory distress. Expiration is a passive action because of the lungs' chest wall system being elastic and wanting to return to its normal resting position, but can be facilitated by the use of abdominal muscles and internal intercostal muscles that pull the ribs downward and inward. The trachea is a conduit for respiration and clearance of bronchial secretions. The average length is 10 to 13 centimeters, surrounded by cartilaginous rings, with the exception to the posterior aspect with thick membrane. The cricoid cartilage is a full cartilage ring and is the most narrow part of the trachea. The trachea bifurcates at the end of the sternal angle, dividing into the right and left. The right is more vertical than the left, the right being 25 degrees, the left being 45. With each division of the bronchi, the mucosal endothelium and supportive structures change. Gas exchange happens only across the flat epithelium of the bronchioles. The deeper you travel down the bronchial tree, there is a loss of cartilaginous rings and replacement with smooth muscle. To maintain patency, the muscle relies on radial traction and lung volumes to remain open. Cilia move the bacteria and debris out of the lungs. The alveolar size is a function of gravity and lung volume, greatest at the apex and smallest at the base, all contacting a network of capillaries. The number of alveoli increase progressively with age, starting at 24 million at birth and the final adult count at age 8 of 300 million. The walls are asymmetrically arranged, thin sides utilized for gas exchange and thick sides utilized for fluid and solute exchange as well as support. There are two types of endothelium within the alveoli. Type 1 pneumocytes are the tight and flat, preventing passage of large molecules but participating in the exchange of gas, and type 2 pneumocytes that contain laminar bodies producing surfactant. There are two circulations of the lungs, the pulmonary and the bronchial. Bronchial circulation arises from the left side of the heart, receiving less than 4% of the total output, causing a normal physiologic shunt. And pulmonary circulation arising from the right side, receiving 100% of the output. Cardiac output from the left side of the heart travels through the body and picks up CO2 from the tissue and returns to the right side for gas exchange in the lung. Cardiac output from the right side of the heart equals cardiac output from the left, and gas exchange happens in a low-pressure system of the lungs in the lungs' capillary beds. The lymphatic channels originate in the interstitial space. Drainage is high in protein content and flows can be up to 20 milliliters per hour. The diaphragm is innervated by the phrenic nerve arising from the C3 through C5 nerve roots. The intercostal muscles are innervated by the respective nerve roots. The vagus nerve is a sensory nerve for the tracheal bronchial tree and also causes bronchoconstriction and increased secretion via muscarinic receptors. The sympathetic nervous system and parasympathetic nervous system innervate the smooth muscle and the secretory glands. The sympathetic nervous system activity arises from T1 to T4, causing dilation and decreased secretions via beta-1 receptors. The parasympathetic nervous system activity is mediated by the release of nitrous oxide. The mechanisms of breathing is based on small pressure gradient changes that are different in the spontaneous breathing patient from the mechanically ventilated patient. Spontaneous ventilation alveoli pressure is always greater than the surrounding intrathoracic pressure. Alveolar pressure is at atmospheric pressure at the end of inspiration and expiration, equaling 0 centimeters of water. Intrapleural pressure at the end of expiration is negative 5 centimeters of water. During inspiration, the chest expands and the diaphragm contracts, further decreasing the interpleural pressure, causing the alveolar pressure to decrease to less than atmospheric, allowing the air to move from high to low pressure. When the diaphragm relaxes, pressure increases interthoracically, forcing air out of the lungs. In a mechanically ventilated patient, positive pressure is applied to the lungs, forcing air in, and is only exhaled when the patient pressure is. The chest has a tendency to expand out, and the lungs have a tendency to collapse. The elastic recoil of the lungs is due to the high content of elastic fibers and surface tension in the alveoli. This surface tension is reduced by surfactant produced by the type II pneumocyte cells of the alveoli, consisting primarily of phospholipid. The surfactant lines the alveoli and reduces the surface tension by disrupting the intermolecular forces between the liquid molecules. This helps increase the alveolar compliance and decrease the tendency to collapse. Laplace's law describes the pressure required to keep the alveoli open. If you increase the surface tension, you must increase the pressure to maintain the same alveolar size. By decreasing the surface tension with surfactant, you reduce the amount of pressure needed to keep the alveoli open. Compliance of the lung can be expressed in the equation of volume over pressure, describing the distensibility of the lungs and the inverse proportionate to the elasticity of the lungs. When the patient's lungs have low compliance, they tend to breathe smaller volumes and higher rates. If the patient has higher lung compliance, they tend to trap air. This requires the use of ventilatory muscles for active exhale. Functional residual capacity of the lung is a measure of compliance of the lung and the chest wall together, with the two forces being equal and opposite. This will be further discussed in an illustration in the next slide. The functional residual capacity is when the pressure in the airways and the lungs is equal at atmospheric pressure of 0. At equilibrium, the lungs' tendency to collapse and the chest wall's tendency to expand are equal. The elastic properties of the lungs and the chest determine the point in where they are equal in normal breathing, illustrating how compliance greatly affects the FRC. Factors that alter functional residual capacity are body habitus, sex, females being 10% less, posture, lung disease, and diaphragmatic tone. Closing capacity is the volume in which the airway closes. It depends on the radial traction and lung volumes. Normally, closing capacity is well below the FRC, but raises with age. Lung volumes and capacities. Using this chart, you can take a look at normal breathing pattern and how the lung volumes are calculated. The tidal volume is the inspired and expired air with each normal breath averaging about 500 milliliters per breath. The inspiratory reserve volume is the maximal additional volume inspired above the tidal volume at averaging 3,000 milliliters. This volume is utilized during exercise. Expiratory volume is the maximal volume expired after tidal volume averaging about 1,100 milliliters. Residual volume is the volume remaining after maximal exhalation averaging 1,200 milliliters. This volume cannot be measured with regular spirometry. The total lung capacity is the total of all the volume averaging about 5,800 milliliters. The functional residual capacity as illustrated in the previous slide is the volume remaining in the lungs after expiration, created by the residual plus the expiratory reserve volume, averaging about 2,300 milliliters. The vital capacity is the volume of maximal air that can be moved, or the sum of the tidal volume, inspiratory reserve volume, and expiratory reserve volume. This is dependent on body habitus, respiratory muscle strength, and lung compliance. Resistance in the airways can be described by Puiseux's law, illustrating the relationship between viscosity, length of the airway, and radius. Viscosity is not only describing the molecules that move through the airway, but the way that the air moves. Gas flows in the lungs in a mixed laminar and turbulent flow within the respiratory tract. Laminar flow is described as a concentric cylinders of gas flowing in different velocities, fastest in the middle and slowest in the periphery, and it is not audible. Turbulent flow is described as the random movements of gas molecules. Turbulent gas flow generally occurs at high gas flow rates and in areas where you have sharp angles or changes in diameter, all increasing airway resistance, and they are audible. Increased airway resistance can caused by bronchospasm, secretions, or edema. Ventilation is defined as the sum of all exhaled gas volumes over 1 minute. Not all air-inspired participates in gas exchange, and non-respiratory airways such as the trachea are anatomic dead space, whereas areas of the alveoli that are not perfused are considered alveolar dead space. The total of both anatomic and alveolar dead space are considered physiologic dead space. You can simply average physiologic dead space as 2 milliliters per kilogram or calculate the exact amount by knowing the partial pressure of CO2 in the arterial blood and the partial pressure of CO2 in the expired air. Minute ventilation is respiratory rate times tidal volume for an average adult being 5 liters per minute. The alveolar ventilation takes into account the dead space and gives the value of ventilation that participates in gas exchange for each minute. The alveolar ventilation is not evenly distributed. The right lung receives more ventilation than the left, and in more dependent areas receive more ventilation than the non-dependent areas due to the pressure gradient changes. About 5 liters of blood flow through the lungs, though only 70 to 100 milliliters participate in gas exchange at one time. Many other factors can affect vascular tone in the lungs, such as hypercarbia, acidosis, hypoxia, hypoxemia, all causing pulmonary vasoconstriction. Hypoxic pulmonary vasoconstriction, or HPV, is important in reducing interpulmonary shunting and preventing hypoxemia. It decreases blood flow to unventilated alveoli in an attempt to maintain a desirable VQ ratio. Like ventilation, pulmonary blood flow is not equal. Regardless of the position, blood favors the dependent regions. It is in the standing position, gravity rules, and blood flows to the lowest at the apex and highest at the base. In the supine position, blood flows nearly uniform throughout the lung. In the next slide, we'll discuss West zones, which describe the uneven distribution of ventilation and perfusion based on anatomic location of a section of a lung. The efficiency of oxygen and CO2 exchange at the alveolar capillary membrane depend on the matching of alveolar ventilation and perfusion. Ventilation-perfusion ratios consider normal ventilation of the alveoli as 4 liters per minute and perfusion of 5 liters per minute, producing a ratio value of 0.8 in healthy individuals. It is stated in previous slides, ventilation-perfusion is not uniform throughout the lung, causing a VQ mismatch in different zones of the lung. The diagram illustrates West zone, showing the size and pressure differences in each lung. Zone 1, blood flow is the lowest and alveolar pressure is greater than the arterial pressure, and the arterial pressure is greater than the venous pressure. The increase in pressure of the alveoli compresses the capillary, further reducing the blood flow. This can be exaggerated with lower than normal blood pressure or excessive positive pressure ventilation. Zone 2 blood flow is medium, but the arterial pressure is greater than the alveolar pressure, and the alveolar pressure is greater than the venous pressure. Because gravity assists in the blood flow to zone 2, the alveoli have less compression effects on the capillaries, making a better match for ventilation in comparison to zone 1. Zone 3 blood flow is highest. The arterial pressure is greater than the venous pressure is greater than the alveolar pressure. This zone is the best match due to its increased flow pressure and adequate distension of the alveoli to allow gas exchange. In a standing individual, it is believed that the best match exists at the level of the third rib. Before we discuss how gas gases are transported through the body, let's review some physics and how gas moves through one space to another. Physics plays a significant role in how air in the atmosphere enters the lung, travels through the tissue barriers, and binds to hemoglobin for the necessary gas exchange. Dalton's law states that the sum of all partial pressures is equal to the total pressure. This allows us to calculate how much partial pressure gas is being dissolved into the blood. If we give somebody room air or 21% oxygen, you can calculate the partial pressure of oxygen by taking atmospheric pressure of 760 and multiplying by its percent. We see that inspired air equates to 160 millimeters of mercury oxygen content for each breath. Once the air enters the trachea, it is humidified, diluting the oxygen as water takes up part of the whole percentage, further decreasing the oxygen content. Henry's law states that if you increase the partial pressure of oxygen, you increase the number of molecules that can enter the blood. When we increase the FiO2 to 80%, we increase the pressure of oxygen available to dissolve in the blood. Fick's law discusses the rate of diffusion of a molecule is proportionate to its partial pressure gradient, high concentration to low concentration, and the solubility of the gas, but is inversely proportionate to the membrane thickness. Not only do the molecules have to reach the alveoli, but they must travel through multiple tissue layers. The more soluble the gas, the higher the concentration and the higher the rate of diffusion. However, if you increase the thickness, the rate will decrease. This can be seen in conditions such as ARDS or in aspiration lung injuries. PO2 is decreased from 140 in the trachea to 100 in the alveoli and equalizes in the blood to 100 millimeters of mercury in the blood dissolved. Graham's law equals the size of molecule matters. The smaller the molecule, the easier it travels. And Boyle's law says you decrease the volume, you will increase the pressure, and this explains how air is inhaled and exhaled. Transport of gas in the blood. Movement of gas across the alveolar capillary membrane depends on the integrity of the pulmonary and cardiac system. Oxygen is carried in two forms, dissolved and reversibly associated with hemoglobin. Henry's law states that the concentration of any gas in a solution is proportionate to its partial pressure. Dissolved oxygen can be calculated by the partial pressure multiplied by the solubility of oxygen in the blood. Since not all oxygen in the alveoli diffuses, or we discussed that alveolar oxygen concentration is 100 millimeters of mercury, you can calculate that 0.3 milliliters of oxygen is in every 100 milliliters of blood. Hemoglobin at normal concentration increases oxygen carrying capacity 70-fold. Hemoglobin is a complex molecule of 4 heme proteins with iron-containing porphins. The iron in the ferrous state is the site where oxygen binds. A decrease in oxygen delivery can be to low oxygen partial pressure, low hemoglobin concentration, or inadequate. Carbon dioxide, which is 20 times more diffusible than oxygen, is produced by the tissue and transported to the lung in 3 ways: dissolved in a solution, combined with proteins in the form of carb-amino compounds, mainly as carbaminohemoglobin, or as bicarbonate, with the assistance of carbonic anhydrase, an enzyme, representing the largest fraction of CO2 in the blood. Dissolved CO2 is very small, and it's free in a solution. Carbaminohemoglobin, again, is a very small amount, and it's where CO2 is bound to hemoglobin. The bicarbonate transport, you start out with CO2, it's generated in the tissue, and it diffuses freely into the venous plasma, then again diffuses into the red blood cells. CO2 combines with water and with the assistance of carbonic anhydrase converts to carbonic acid. Carbonic acid then dissolves to form hydrogen and bicarb. The bicarb leaves the red blood cell in exchange for chloride ions and travels into the plasma. This is where they have the chloride shift. Hydrogen is then buffered by the red blood cell. Once the blood reaches the lungs, this reaction is then reversed. The hemoglobin dissociation curve. Hemoglobin binds up to 4 oxygen molecules, and the definition of saturation is based on the percent of hemoglobin that is occupied by oxygen. There is a nonlinear relationship between hemoglobin subunits binding with the oxygen due to its change in affinity of hemoglobin to each successive oxygen molecule, explaining the S shape of the curve. This change in affinity facilitates the loading of oxygen at the lungs, the flat portion, and the unloading at the tissue, the steep portion. 4 separate chemical reactions occur to bind each oxygen molecule, but with each molecule binding, the reaction is accelerated for the next. At a PaO2 of 100 millimeters of mercury, hemoglobin is 100% saturated. A mixed gas, P venous O2 of 40 millimeters of mercury, the hemoglobin is at 75% saturated. Factors that affect the affinity of oxygen to hemoglobin cause the curve to shift from right to left and are listed in the chart. A right shift suggests a decrease in affinity, making oxygen more available to the tissue, where a left shift causes the oxygen to remain in the hemoglobin, making it less available to the tissue. Control of breathing happens by many mechanisms, and it is a result of neural activity in the respiratory centers within the brainstem, regulating respiratory muscles to maintain normal oxygen and carbon dioxide levels in the body. Sensory information such as PCO2, lung stretch, irritants, muscle spindles, tendons, and joints coordinate with the brainstem. Output of the brainstem controls respiratory muscles and the breathing cycle. Central respiratory center, you have basic breathing and rhythm, originates in the medulla. The dorsal respiratory group is active during inspiration, generating the basic rhythm of breathing. The sensory information input arises from the vagus nerve and the glossopharyngeal nerve, whereas the output travels through the phrenic nerve to the diaphragm. The ventral respiratory group is active during expiration and is not active during normal breathing, however. As expiration is passive. The ventral group is activated during exercise or when exhaling becomes an active process. The apneustic center is located in the pons, and it stimulates inspiration, producing deep breath and prolonged gasp. The pneumotactic center is located in the upper pons and inhibits inspiration, regulating volume and rate. And the cerebral cortex allows for breathing under voluntary control. Central receptors, such as chemoreceptors, respond to changes in hydrogen ions within the cerebral spinal fluid and are located in the medulla. A decrease in pH will cause an increase in inspiration. Peripheral receptors, such as peripheral chemoreceptors in the carotid bodies and aortic bodies, are sensitive to changes in the PaO2, responding when the PaO2 is less than 60 millimeters of mercury, PaCO2, and arterial perfusion pressure. The carotid body's ventilatory effects are characterized by an increase in breathing rate and tidal volume. The aortic body's effects are characterized by bradycardia and hypertension. The lungs also have receptors to include pathways involving the vagus nerve and stretch receptors, inhibiting inspiration with volumes become excessive. Again, other functions of the lungs are metabolic: surfactant synthesis, metabolism of vasoactive compounds, histamine synthesis, and the conversion of angiotensin 1 to angiotensin 2. Let's review some of the literature. General anesthesia causes impairments in gas exchange and respiratory mechanics, often forming atelectasis. Laparoscopic procedures further worsen the mechanics in healthy, weight, and obese patients, increasing the pressure on the diaphragm during expiration and decreasing end expiratory volume. This study by Futer et al. Evaluates the effects of position, PEEP, recruitment maneuvers, and the combination of these interventions on healthy, weight, and obese patients. They did an evaluation of 60 patients, 30 healthy, weight, and 30 obese, undergoing laparoscopic procedures ranging from hepatectomy to sleeve gastrectomy, and they evaluated the effects of anesthesia on induction and the pneumoperitoneum insufflation and effects of ameliorating the problems with PEEP, recruitment maneuvers, and how they affected the end expiratory lung volumes, static elastance, oxygenation, and dead space. Both groups showed relatively equal compromise in the end expiratory volumes and PaCO2 with insufflation of the abdomen. The use of PEEP of 10 centimeters of water significantly increased end expiratory lung volumes in both groups by 46%, also lowering the PaCO2 in both groups, but did not change oxygenation. The use of recruitment maneuvers further increased the end expiratory lung volumes from 150 to 230 mils, benefiting obese patients more than healthy patients. Gas exchange was also improved between the two groups, something not seen in the PEEP group alone. Recommendations are to utilize PEEP of 10 centimeters of water combined with recruitment maneuvers sustain improvements of the end expiration lung volumes, gas exchange, and respiratory mechanics, and may be useful in counteracting detrimental effects of pneumoperitoneum. And another study took a look at postoperative residual neuromuscular blockade, as it is common, and in the absence of pharmacologic reversal, can occur in up to 42 to 57% of patients, impairing airway integrity. The upper airway integrity may be altered without effects of the respiratory muscles, leading patients to postoperative respiratory complications. This statistic leads providers into the practice of utilizing reversal pharmacologic agents. Evidence exists, however, that administering the reversal agent in the absence of blockade can impair evoked peripheral skeletal muscle strength in humans. Herbstreit et al. Hypothesized that neostigmine administered after the recovery of train of 4 ratios impairs upper airway integrity and genioglossus muscle function. 10 healthy male volunteers assessed epiglottic and nasal mask pressures, genioglossic electromyogram, airflow, respiratory timing, and changes in lung volumes before, during, so train of 4 of ratio of 0.5, and after recovery of train of 4, and after administering neostigmine of 0.03 milligrams per kilogram or glycopyrrolate 0.0075 milligrams per kilogram. Upper airway critical closing pressures were calculated. The results showed that the critical closing pressure increased significantly after administration of neo and glyco compared to both train of 4 recovery and baseline. Genioglossus muscle activity was markedly impaired after the administration of neostigmine and glycopyrrolate to the spontaneously recovered train of 4 patients. It did not affect the lung volumes or other respiratory variables. All 10 volunteers reported difficulty swallowing normally, and 5 reported diplopia. The conclusion was that neostigmine glycopyrrolate, when administered after recovery of neuromuscular block, increased airway collapsibility and impairs genioglossus muscle activation in response to negative pharyngeal pressure. They state that it is undesired to use a reversal agent when neuromuscular blockade is absent. So here's some food for thought. What does the literature say about the criteria to reverse a patient, and how do you know if the neuromuscular block is absent? If you have any questions, feel free to let me know. And here are my references. Thank you so much for your time.